Ladies and gentlemen, I would like to start the next session and to open it. As Cody Bünger outlined, trauma is a major burden the world's population is focusing. Thus, best trauma is the one that doesn't happen, and this is what injury prevention is focusing. My name is Karl Hasper. I come from the Hanover Medical School, and I work there as a Department of Trauma Surgery as a member of faculty. And my co-chair is Professor Günter Lob. He's from Munich. He's a retired professor of trauma at the University of Munich and was the chairman of the Department of Trauma Surgery in the hospital in Großzahn. And he will start to introduce our working group in the German Trauma Society.
Ladies and gentlemen, I'm very happy that some of the Congress participants are attending this session on prevention. I know everybody is very anxious that prevention make the trauma surgeons jobless, but this is not the case, I can assure you. Now, trauma, as Cody Bünger just mentioned, is the main burden for the next 20, 30 years all over the world. And to prevent trauma, I think this is a very medical opportunity, and we are trying to do so, and there are some very interesting developments in Europe, outside Europe and United States and all over the world. So we will focus on some of the aspects and show to you what is on the way for the next years.
Yes, and I would like to invite the first speaker. He's Matthias Ruppert. He's a medical doctor and he works for the ADAC, which is the largest German automobile club. It was founded already more than 100 years ago. Interestingly, as a German Motorbikers Association, but was renamed quite early, being the German Automobile Club. Yes, everyone in Germany knows ADAC because they support us on the roads with mobile mechanics called the Yellow Angels. And those mobile mechanics assist motorists in trouble on the roads. However, there's another fleet of Yellow Angels. Those are the ones with the helicopters who we will see on scene after major traffic accidents. So he's going to talk about cross-border concepts in air rescue and transport in the European Union. Please.
Dear Chairman, dear colleagues, I want to thank you very much to have the opportunity to talk a little bit about what is going on, happening in, let's say, the delivery services to your hospitals, and with a special perspective on cross-border air rescue. We are not able to prevent trauma, but our task is to bring the patient in the right time, in the right hospital. And this perhaps not only within a country, but also over borders. But if we talk about borders, we have to clarify what kind of borders we talk about, or better to say, what kind of borders we have to fight against. And to clarify that a little bit, let's take a look on Germany, the country I come from, and very similar structures and mechanisms play a role in any kind of country concerning EMS. In Germany, the responsibility for EMS lies in the 16 different states who define independently how EMS should work. Some of them do have nationwide coordination centers for inter-hospital transfers, others do not. And beside that, the EMS itself is organized by the cities and counties themselves, with no formal interaction between these levels of administration. So if you want to talk about international cooperation, it's often even unclear on what administration level we should talk. There is a federal structure in the one country, here Germany, and perhaps a national responsibility in the neighbor country like in Czechoslovakia or France. So already at this point it becomes very difficult to organize and establish international corporations. And if you look further into the structure, we still have about 300 EMS districts and corresponding rescue coordination centers in Germany. And you see on the map, there are areas where several counties come together for one EMS district, and there are other regions where each city and county has its own dispatch center and wants to keep it. And between these EMS districts, there is a variety of responsibilities. Some do only rescue, some do fire and rescue, some do even police fire and rescue. They have very different strategies, and in almost all these dispatch centers, there is no means of quality assurance and no medical control. And between these EMS districts, there are borders. And to more clear for you as a typical example what we fight against, I want to show you two examples from a study in Bavaria. And to get you better oriented on this map of Bavaria, this is a place where Oktoberfest starts again in 2 weeks, the city of Munich. Down in the south is Neuschwanstein, the famous castle you may know perhaps, and in the north the city of Nuremberg with its famous Christmas market. These lines you see here represent HEM spaces, and the thicker the line is, the more missions are flown into a designated county. And if you pick out one region, for example here in the northeast of Munich, you see counties which would be well served by 4 helicopters around, but there are no missions. So we have to ask us, what happens to patients who have a major trauma here, or a myocardial infarction or a stroke? Where do they end up? Because there is no major hospital in this area. And we have to say we do not know where they end up and what happens to them. So obviously, air rescue methods are just ignored in this area. This graph shows the relationship between missions served by ground-based doctors versus by helicopter. The darker the color, the higher is the percentage of HEMS missions for life-threatening situations. And if we again pick out an area here in the south west of the state of Bavaria, you see in the north area of this county, there seems to be a high necessity to send helicopters pretty often to reach the patient in the right time and to bring a hospital. And if you just walk across this border of a county, air rescue basically does not exist. And again, we still have no idea what happens there and what's the dispatch strategy of this area in the north. But despite all these problems within the country, there are positive news saying that, of course, cross-border air rescue from one country to another takes place. For example, to Belgium and the Netherlands, with 2 helicopters here. There's one base we operate together with our Austrian colleagues. The Dutch colleagues from the University of Groningen help a lot in the northwest of Germany. There's a very successful project from the colleagues of the DIF Air Rescue, the other big civilian operator in Germany, on the border to Denmark. And even the federal helicopter here does fly to Netherlands. Surprisingly, the only region where there would be a formal state contract between Germany and France, there are almost no missions over the border between these 2 countries. And there are also organizations from other countries who fly into Germany, like from Luxembourg, from Switzerland, several operators from Austria. And that all takes place. But if you look at the obstacles and the difficulties, it's surprising that we can realize it. And the biggest obstacle, perhaps, is the different personal structures and the different procedures we perform. First of all, of course, language barrier is a problem more to countries like France or Poland and Czechoslovakia than to Austria and Switzerland. We have completely different EMS systems. We have a physician-based system in Germany and, for example, a paramedic-based system in the Netherlands. Therefore, paramedics are allowed to do much more than German paramedics would be allowed to do. How to deal if the one or the other comes across the border. And therefore, we have different level of qualification and training programs. And the role of air rescue is different in the countries. While in the Netherlands, for example, again, the helicopter is mainly a trauma helicopter. The percentage of traffic accidents in our missions, meanwhile, is less than 1/3. And completely different documentation tools, protocols, and things like that. But even more, technical requirements make a problem, and first of all, our communication systems. And communication means not only the communication between the coordination center and the helicopter, but also between the helicopter and the rescue units on scene. And data processing to the receiving hospital is completely different, organized in different countries. But also the incompatibility of stretchers or other medical equipment like oxygen supply makes a problem in the mission. You have different drugs and different drug names, and last but not least, the legislation and administration. And I stated already earlier, the different responsibilities in the countries makes it difficult to talk about cooperation projects. Even being in Europe, we have a variety of flight regulations, medicine-associated laws are completely different, and the setups for the EMS system. And what is more difficult, the way how rescue missions are reimbursed is very varying throughout Europe. This very successful project of the colleagues between Germany and Denmark, performed since 2005. I only want to show you one graph out of their project, and you see, without translating this, how complex the process is and how many aspects have to be considered until after 3 years and a lot of effort, there was a working system of cross-border air rescue in this area. One special focus, if you talk about international cooperation and cross-border air rescues, are surely mass casualties. Here, the relevance of air rescue resources is especially high to make it possible to transfer patients of instances to the number of hospitals which are needed in these cases. But in these cases, it becomes especially complicated if you don't know a system and if you enter with your rescue helicopter into unfamiliar EMS structures. You maybe remember this catastrophe at the Love Parade in Duisburg a little bit more than a month ago. There were 7 helicopters from 5 operators out of 2 countries, and at the time the helicopters came, there was a complete breakdown of all communication systems. So if you do not know the system you work in at this time, you run into problems. And it's better you know a neighborhood EMS system during routine operations before you work together in a mass casualty like that. We put a lot of effort in making the availability of air resources better visible for the dispatch centers. And meanwhile, we have a web-based information technology via a satellite technology which gives dispatch centers an opportunity and the possibility to see where the helicopters are and whether they are available. And this over the frontiers and borders of EMS districts. For this example, you see here again the city of Duisburg, and it's a screenshot from yesterday afternoon. And you would see that these 2 helicopters are at the moment in a mission on scene, and that this helicopter is at this destination hospital and should be available pretty soon again, and that there are another 3 helicopters around which could be dispatched to an emergency immediately. The tools like that may help to make cross-border rescue much easier in the future. Finally, I want to give you one good example for international cooperation in air rescue, which is not mission-based, but strategic. The EU project on training, financed from the Leonardo da Vinci programs, we were in the very happy situation that we could establish a human factor course configured specially for HEMS operation, focusing patient safety but also flight safety in this very mixed groups of pilots, paramedics and doctors from various countries. And this course and training program was established by experts from all operators and countries you see below, and has become a very successful exchange program, far more than initially thought by the just initial idea to establish a training. So putting it all together, there's a variety of obstacles making international cross-border air rescue difficult. And before planning new project, we should have good scientific data to know where it makes sense to start project and to invest into these methods. Local problems need local solutions, and therefore it may be best to proceed with regional initiatives to establish HEMS projects in border near regions. And finally, we think that there's a great potential for strategic cooperations, for example, establishing training programs or standardizing technical means strategies in air rescue. Thank you very much.
Thank you very much, Mr. Ruppert. Now, please stay with us. Are there any questions in the auditory? So we have a very small auditory. If you like, you can come down and ask directly. So may I ask you, what are you proposing to a society like SICOT to overcome this political problem on the borders of rescue systems?
Well, as I stated, one serious problem are surely the complicated billing systems between countries. And what's happening if a German patient ends up in an Austrian hospital, if a Dutch patient is brought to a Belgian hospital or something like that. And we have to find structures to make this exchange of patients and reimbursement of resources easier than it is up today.
So, do I understand you right? This is more or less a political problem, and we have to influence the public opinion to get these problems solved. It's not a medical problem. It cannot be solved by the doctors, by the orthopedic surgeon.
No, it's doable. Of course, we can treat patients on both sides of borders, but we have difficulties in the legislative basis, and of course in the systems of reimbursement, of course.
Yeah, therefore it's fantastic to see that we have a golden hour, so 60 minutes to bring a polytraumatized patients to a good treatment, and 20 golden minutes for the children. We have wonderful systems. We train doctors, like here at the SICOT, but in between there is a gap which we have to fill to overcome borders in the treatment of patients, especially borders of payment. Now, are there any questions out of the auditory? Then thank you very much. Hopefully we will have the next meeting with some people more attending the prevention session.
Yes, and I would like to introduce the next speaker. So also we know that 1.3 million die each year on the world's roads, and most of the talks are focusing road traffic related death and accidents. We have to know that most of the accidents happen at home, and Stephanie Merzhäuser is focusing this topic. She is an attending surgeon in pediatric surgery at the University Hospital Charité in Berlin, and she's quite active for more than 10 years now on a nationwide program focusing prevention of children accidents. Please.
Thank you. After a bit of a theoretical talk about prevention, I would now give you a few examples of what I would call hands-on prevention. Why should we use exhibitions? Exhibitions are a very attractive tool to introduce accident prevention to public. And I think the most important thing, and this is one of the things we see here today, is to attract public awareness that accident prevention is important and that safety issues are something everybody should know about, talk about. So we try to address visitors in an emotional way, and we want to address as well parents as children by exhibitions. I will show you the exhibitions later on, so that children and parents can learn by doing how to prevent accidents. And another positive aspect of exhibitions is that they usually really are attractive, and this is something that the media like to communicate. Talking about prevention is difficult because, as we have learned before, it's always difficult to find evidence-based studies. So what does work in accident prevention? If you look into the literature, there are different studies on accident prevention. For example, there are educational campaigns, like people being advised, like personal advising of parents, or you hand out brochures and information, or you sell safety devices. But does this really make a difference? Looking into the studies from 1979 to 2004, we found 13 studies where where it was tried to measure the competence of accident prevention. In pediatric practices, children's hospitals, and at home, parents were educated on accident prevention. But looking at the evaluation, the question is, did we achieve something by this education? So in these studies, what we found was, yes, there is a behavioral change. Yes, there are reduction of safety hazards in the homes of the participating families. The families did use more safety devices after the educational program, but nobody has ever found out whether really a reduction of accidents followed the educational program. So, looking into other studies, we found that if you want to make accident prevention more effective, it is helpful to give complementary or price-reduced safety devices such as smoke detectors, window bars, or bicycle helmets as a sort of handout to the parents or health caregivers in combination with education. So once again, evaluation, we found behavioral change, yes, a reduction of safety hazards in the home, and the very positive aspect, even a year after the educational program, the safety devices were still in use, but there was no measurement of really a reduction of accidents. I now want to give you a few examples from Germany, from Safe Kids Germany. Safe Kids Germany is a nationwide campaign to reduce childhood injury, and we have different aspects, and one of the programs we're doing are exhibitions. One of our first exhibitions was an exhibition for adults called The Giant Kitchen. And this giant kitchen was traveling and is still traveling through Germany. And the focus of this exhibition is that parents can make, once again, experience of being an 18-month-old child. When you stand in this giant kitchen, you cannot see the hazardous situation of the hot stove. And this exhibition is always very useful for parents. It is useful for press. You always get a lot of interest when you present the exhibition, because people can really understand why children have accidents in the kitchen, because they do not see what we as grown-ups see. We try to evaluate the effect. We had 50,000 visitors of this giant kitchen in 50 locations, and we questioned the parents, and 77%, and I think this is quite a high percentage of visitors said, oh yes, they would like to visit an exhibition comparable to this one again. So we did with a greater exhibition that was based on the giant kitchen, which is called Children in the House. So now you not only have the kitchen, but you have a table, you have chairs, all in an oversized manner. And once again, grown-ups have the opportunity to feel like an 18-month-old child again, and to see why children, for example, would climb on the fences, or why would children grab at poisonous cleaning things? Why would they climb on shelves? Because it looks totally different from the perspective of a 1.5-year-old child, or probably 2-year-old child. Another exhibition that is quite useful is, we call it the Pillars of Safety. It is easy to handle exhibition in comparison to the two exhibitions I showed you before. The giant kitchen and the exhibition Children in the House. You can imagine it's a great, it makes a great lot of hassle to travel these exhibitions, while the exhibition, the Pillars of Safety, is easy. It can be packed in 4 quite large suitcases, and then it can be put up in any pediatric practice or in a hospital. The fun about this exhibition is that it can be easily combined with giving away of safety products. You don't have to explain very much, because the exhibition explains in itself, and you can also address migrants that are sometimes not that easy to reach because of language barriers, and try to always, if we address migrants, find someone who himself is a migrant and therefore makes easier contact to the population. If I, a blonde German, stand there and try to educate Arabic women, this always gives a bit of a wrong impression, so it's much better to find a doctor from Lebanon giving the important informations. Another example addresses a wholly different group. It addresses the children, because I'm a mother of 3, and up to the age of approximately 3 to 5 years, you can protect your children by saying no. But once they are older, they will not react to a poor no. They will understand why something is different. So we try to address this change in children with the Hazardous House. This is a hands-on exhibition with schoolers or small school kids, which is integrated in a large firefighters' village in Iserlohn. The fun about this thing is it's a small real house, which is made, what I like about it is it's quite modern, and it's a combination of drawings, but as well of hands-on exhibitions. Like, you can go into this kitchen and you have the drawings on the wall, you have the entrance room, but the staircase, for example, is real, so the children can understand why a fall from a staircase could be dangerous. There is a little doll. Children can learn how suffocation happens and how small parts could enter their throat. And then we have, for example, this bathroom, which shows danger situations in the bathroom. Instructors accompany the children. They are qualified in a seminar, and then the children are guided through this house, and they have the chance to learn on a magnetic board, what is a hazardous thing. So the children will go out and hopefully they will have learned something. So to conclude, we think exhibitions are an attractive tool in accident prevention. if you combine a pure exhibition with education, they will hopefully contribute to initiate behavioral changes. Furthermore, safety giveaways can improve the impact because people will use the safety equipment. It is still important that evaluation to prove effectiveness is lacking, and we still need evaluation models that have to be established. So to make accident prevention very effective, we have to have accurate sources of data on pediatric trauma so that we can really identify the problems and identify the target populations to plan then realistic goals for injury control strategies. And, well, last but not least, we should really then evaluate the success in meeting such goals. Thank you for your attention.
Thank you very much, Mrs. Merzhauser. I'm always fascinated, and we had this giant kitchen at the German Trauma Society meeting with about 3,000 attendants, and was really interesting to see how the doctors are handling all these equipment up in the height, and to learn that really children are not small adults, children are different. Now, are there any questions? Yes, please, our president.
Yes, thank you. I'm impressed by your setup, and but I would like also to know what is I mean, if you look at the pediatric injuries, I mean, which can be prevented, what are the main areas? So is it in the home? The home is serious, I know. The institutions, the day institutions, you know, where we put the children in the daytime compared to the traffic. What is it? I just thought, you know, this is the case now because of with some of the problems, for instance, injuries to the children during driving, you know, where we actually now we are getting punished if we take the mobile phone, and I think you should lose your driver's license if you drive with an unsecured child in your car or whatever, things like this. So I would like to know a little about the perspective.
So if you look at the epidemiology of injuries in children, it is very much age-related. The age group of 0 to 3 or 0 to 5 has mostly home accidents. So in the age group from 0 to 1, the most frequent accident is fall from the dressing change table. So a very easily preventable accident if you tell mothers just to keep one hand on the baby while changing the diaper. The older the children get, the more mobility they achieve, and the more they are, the more the way of the accident changes. So a 5-year-old will have more accidents on the playground or driving a bicycle without helmet, and then the older the child gets, the less it is in the home and the more it is on the roads. So with these exhibitions, we try to focus on the home and leisure accidents because especially in Germany there is very good accident prevention on road accidents. There are courses in schools, and children learn a lot about accident prevention on the road and road safety. But there is nobody who's really taking care of safety in the home. And we have a large population of migrants in Germany, so especially in Berlin where I work. And it is very difficult to reach these migrants. They have different ways of handling their children. They are, in many cases, they are socially not so achieved. So migrant children have dramatically more accidents. Like Turkish boys have a 5 times increased rate of burns up to their 5th year. So we really focus on telling migrant families how to protect their children.
Thank you.
Are there any other questions in the room?
Maybe I've got one question. So I guess the Giant Kitchen addresses parents' attention And is it maybe more important to catch the kids' interest up in potential preventive measurements like with Florian's Village? So are there any results from the literature or your own experience which approach is more effective? So
yeah, I think that's the big problem. There is no literature that really proves what is more effective. I personally would really draw a line between small children and accidents of teenagers. In the small children, it seems to be the best to educate the parents, but the older the children get, the more important it is to focus on the children and make them risk competent. And this is the sort of new trend in child safety, that we try to make kids risk competent, and especially in teenagers. There are nice campaigns like Split Second, which is a campaign from Austria addressing teens and twins, that they should not have so many accidents for example, on motorbikes.
okay.
So I think it depends on your focus group.
Thank you very much, Frau Merzhauser.
Okay, so we would like to get further on. So I would like to welcome the next speaker to the floor. Is Uli Schmucker, co-chairman in the German Trauma Society's Injury Prevention section. And he's focusing something different. So we know that 90% of the fatalities on roads are in low and middle income countries, but those have less than half of all the vehicles which we have on the whole world. So he's focusing another hot topic to the countries with a little or middle income, and he presents a talk on Think Auto in the German cluster development initiative to dedicate to urban road safety. Please.
Thank you very much, Mr. President, ladies and gentlemen. My name is Uli Schmucker. I'm an orthopedic and trauma surgeon. However, I spent substantial time of my career outside a hospital, and substantial time I spent in India and other European countries working in mainly road traffic, crash prevention, and road safety projects. And two of them I would like to present to you. So the first is a project called, or an initiative called Think Auto, a German Indo initiative. So let me briefly introduce you to some highlights from India. We all know that India is a huge country with a population of approximately 1.2 billion people, and as Mr. Hasper already told you, it's a low-income country. That means that almost half of the population lives from under $1 per day, which is a significant problem whenever we are talking about road safety and any associated interventions. However, when we are talking about low-income countries, it's not sufficient to talk about the figures that we know from today. It's much more important to respect the estimations and prognosis in 10 years or in 15 years' time. One important change will be the increase of the urban population, because this is the hotspot where the traffic accidents occur in India. It's not the rural. And even more important is the exploding the increase of the middle income strata of the society, because this means that in 10 to 15 years, the majority of the Indian population will have access to health care, including emergency care. But on the other hand side, they will have access to motorized vehicles, meaning that there is by natural an increase of road traffic crashes to be expected in India. Nowadays, the registered vehicles share in India is completely different to Germany. Well, that's no surprise to all of us, but maybe it's a surprise that still, when we compare it to the population, there are more powered two-wheelers, for example, in Germany than in India. Everybody of us probably knows high-density traffic areas from the movies or from the news from India, and everybody is probably a bit surprised. We still have more powered two-wheelers in Germany, but that's a fact. That means that in India there's very few high-density traffic areas, and that's where Think Auto addresses the problems. So So when we are talking about road fatalities in India, we have to respect, or we have to look on estimations. Today we have approximately 120,000 road traffic fatalities in India each year, and the WHO projects this number to rise to 250,000 up to 300,000 a year in the year 2025. This is an enormous number, and every effort is needed right today to fight this problem even today. So these fatalities are mainly motorized 2- and 3-wheelers, that's no surprise to all of us, followed by cars, pedestrian and cyclists. But you already see on this very simple slide that there's a high percentage, a high share of 40% unspecified road traffic fatalities, and that gives us an impression of one of the key problems in India. We actually just don't know what happens on these roads. So there's a high share of 40% where we know that the patient is dead, but we don't even have the basic information, what type of vehicle was he sitting on, or was he hit by a bus or whatsoever. We just know he's dead, that's all. And there's another problem from the clinical perspective, because many of these patients are not registered by official statistics. We have 78% that are registered in statistics from fatalities, but we have only 17% of those that are injured and inpatients, only 2% of road traffic victims that are outpatients and in fact registered in the official statistic. That means that all the figures we are talking about are only very, 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 very conservative estimations of what actually happens. And when we take into account that we don't have data and we don't have lots of information, it's no wonder that this epidemic in India is also under-researched. Only 0.1% of the Indian public health research output is dedicated to road traffic crashes, despite the fact that road traffic crashes are one of the major killers of the young population in India. It's not only about HIV or diarrhea or what we all know. Also in the Medline listed publications, we have only 0.7% of the road traffic crash output from Medline that is dedicated to India, despite the fact that India alone accounts for 10 to 15% of all road traffic crash fatalities worldwide. The impact on the Indian health system is enormous. India has to spend more than 3% of its gross national impact each year to deal with the consequences of road traffic crashes. These victims account for 20 to 50% of emergency room admissions and for 10 to 30% of all hospital admissions. So many experts agree that the pre-hospital care in India is the key problem. There are structural problems, there's no trauma system like infrastructure. The dense traffic in the urban area limits the rapid access to the patients, and in consequence, more than 80% are actually transported in motor rickshaws to the hospital or in comparison of public transport. But it's also a qualification and training problem. Only 4% of emergency personnel has any certified training, and almost 0% receive any basic first aid on the scene of accident by laypersons. And still under 5% receive first aid by any healthcare professionals. So, what can ThinkAuto do? ThinkAuto cannot or does not only address the purely medical problems, because road safety and road traffic crashes is also a problem of an environment. And this environment is often addressed as the so-called steep factors, means society, technology, economy, ecology, and politics. And ThinkAuto addresses all of these. Just to give a few examples, this is an endless list, but I only give a few examples. Still, there's no suitable ambulance car for an Indian megacity. It's not about equipping an ambulance that we know with perfect tools. It's about the structure to get any vehicle to the scene of accident. In India, there's still no lead agency that deals with road safety or with emergency care. Private companies are on the rise but they don't publish their results of evaluation studies. Religious attitudes and beliefs restrict the first aid, and dense traffic limits the transport. I already highlighted this. So Think Auto is still in its very beginning, and it was founded almost 2 years ago. We decided to work on 4 issues. One is to synchronize business terminology and methods. One is the socio-technical system of safe mobility. One is the political implications behind road safety. And one, and that's what I'm working on mainly, is how to improve the pre-hospital care in urban areas in India. So we are coming from 4 different points, but we are all ending up in road safety. This is a list of some of our partners. You can see there's road traffic crash researchers, STEEP researchers, clinical researchers, traffic planning, infrastructure, most of them from Germany. And on the other hand side, there's some of the most renowned institutions in India, which I all visited. I lived in India for almost 1 year, working in several of these projects. And the purpose of Think is to interconnect all these partners. So what happened in this year? We did a lot of networking. We had a first joint publication on motorized rickshaw injured, which is in press. We had lots of presentations. We were part of a delegation of the Ministry of Education and Research to India. We finalized the white book, which will be published soon. And yeah, we are on the way to gather more grant applications or to gather more grants in order to start a new project next year. If you are interested to support us, or if you are having any networks in India or Europe, I would love to further talk to you on this issue later after the session. Thank you very much.
Thank you very much, Mr. Schmucker. Is there anybody from India in the room? I think it's a little bit unfair if we are talking about India and the problems in India without Indian people here in the room. Unfortunately not. Now, may I ask you, when I travel in non-industrialized countries, you find huge army facilities anywhere. They have helicopter, they have rescue systems for the army, but when you ask the population there, the army is not dealing with the need of the population and they are not involved in rescue. Is this not a topic to start with? So 50 years ago in Germany, the US Army and later on the German Army started with the helicopters, and then the ADAC took over in a private way. What happens in, for example, India and the Indian Army?
You addressed a really crucial problem. Road safety is still not a political priority issue in India. The United Nations and the World Health Organization announced the upcoming decade as the road safety decade, following the bone and joint decade. And this might give the necessary political support, I mean in a global context, the necessary political support, maybe to convince other stakeholders, other governments, other administration forces, and so on, to share their forces for the sake of a better and improved road safety. To my knowledge, today there is no cooperation between military forces, police forces whatsoever in the purely road safety issues.
Are there any questions in the room? Please ask him about the Indian situation. I think this is a very interesting point. Yeah, please, come on. Please take the micro.
Thank you very much. Although I was interested in this, your lecture, and I was interrupted by a call. But I have because I'm Dr. Ofia from Nigeria. We have this problem of road traffic accident. I want to know whether you have experience. Our problem really is the victims, and most of them are really in transit. And you find out that we have a problem treating them. And they come and they don't have the finance to take care of treatment because most often they are in transit. What is your experience on this kind of problem? Because it limits also what we do for them or the treatment. And what's your experience and what do you suggest, to tackle such a problem? Thank you very much.
Thank you very much. This is a substantial problem. In India, still the financial status trigger the type of healthcare and also the speed of healthcare, especially when it comes to emergency care. We did a one-year hospital-based study in the city of Hyderabad, which is an 8 million metropolitan area in the south of India. And whenever we documented a patient that has been transported to one hospital, then transferred to the next, then transferred to the next, we knew he was from the lowest of the lower socioeconomic strata, because these patients are brought to one hospital, but they cannot afford treatment, so they are directed to a next hospital and so on. I don't have a final solution for this problem, to be honest. In India, they are trying to sort of mandate at least a basic treatment in the first hospital that the patient is actually brought to. I don't know exactly the situation in Nigeria, to be honest, and I don't know how the insurance status is in Nigeria. In India, the big hope is that more and more people will have access to an insurance, and more people will have access to emergency care by having an insurance.
Thank you again. I think this is really a fabulous job, and I wonder again, what is the injury pattern? I mean, is it cheaper for the government to have a dead person than to have an injured person, which needs all the treatment, if you have a spinal injury and you're very bad off, there's no system really to help, and so I wonder what are your primary targets, in terms of how to intervene. It's so difficult. You cannot change the accumulation of people in specific industrialized areas. But I think you must have some experience from the transition from industrialized to a little more healthy system. There must be some systems where you can actually see you are able, by separating the various components of traffic, things like that, which could be helpful and cheap. I don't know. What do you wish?
Our goal is not to help polytraumatized patients in India, because this patient is not frequent, first. And second, we will probably not be able to help him facing the limited resources, facing the time sensitivity of a multiple trauma patient. Our goal is to provide basic but sufficient first aid to those who have moderate severe injuries, because still these people are dying in India. They have injuries that are in no way that are survivable, if only you have some basic first aid. So these people, for example, have open fractures, soft tissue infections are coming. So these people are dying 2 or 3 weeks later because they cannot afford treatment. And there are simple means to treat these people if only they get this treatment in the first hours or the first days.
But, you know, I just focus on prevention. You know, I thought, what are your main wishes, you know, to prevent these injuries? I mean, what would you tell at the moment if you had billions of dollars or whatever?
Then I would separate the different traffic streams, which is one of the most significant problems, not only in India, also in other urban cities. Mixed traffic streams, we see motorcyclists, auto rickshaw drivers, pedestrians, a bus driver, a bus. What else do we see? A car. They are all sharing one road.
But even when I drive into the airport in Paris, for instance, I'm there with a slow Mercedes, and then we see the motorbikes coming like this, you know, and it looks very dangerous. But apparently, this thing is much more dangerous.
Right. The motorcyclist in Paris knows that the Mercedes-Benz stays on his lane. The motorcyclist in India does not know if the motor rickshaw driver stays on its lane. Probably he will not.
Yes.
Thank you very much.
I think we will move on, so we will come from the countries with low income back to the industrialized countries, and the next talk will be provided by Dr. Schmucker too, and I would like to outline his co-author is Dr. Koch. He's a member of the European Parliament, and interesting, he started an initiative, it's called DocStop, and this is the topic of the next talk, which is highlighted as improving health services for long-distance truck and bus drivers, initiated DocStop. Please, Uli.
Thank you very much. So back from India to Europe, this is a much more mature project which is already running and is about to roll out over Europe. The initiative is called DocStop. So we can measure the road transport capacity in billion ton kilometers per year. And we see, and this is a projection by the EU Commission, we see that they project an increase of road transport capacity by 30% over the next 20 years. That means that we have more trucks on our roads, and that means that these trucks have more kilometers to drive, and that means that we have more truck drivers on the road. That's a very simple association. Heavy vehicles, so-called trucks, are involved in almost a quarter of all fatal crashes in Europe, and they are also involved in approximately 10% of those crashes resulting in major injuries, and also 10% or 11% of those resulting in minor injuries. So this is a substantial source of morbidity and mortality whenever we are talking about road traffic crashes. However, if we break down this crash rate to the distance driven, in this case it's 1 million kilometers, the crash rate of cars and other private vehicles is almost equal to that of commercial vehicles like trucks. So there's typically 3 major crash causes, one of which is failure to adapt speed, which is often associated with a fatal or at least a major injury on the side of the truck driver. Second one is failure to follow intersection rules, where the fatal or major injury is mainly on the side of the other road user, meaning the opponent road user, while there's a third major crash cause, which is the inattention or fatigue complex. And some authors also pointed out that this is probably the most important crash cause when we are talking about occupational driver. Next, there's mostly unspecified interaction with health-related risk factors, such as long working hours, night shifts, sleep apnea syndrome, non-compliance with medical drug or non-availability of medical drugs. And these crash risk factors are very, very difficult to determine because the police officer has almost no opportunity to actually document these factors or to investigate these factors. However, we know from a lot of study that they interact with the crash rate. Who actually is this vehicle driver that we are talking about? He's male. He has a comparably high median age if we take into account that he is doing a very demanding physically job. Most of them have no formal job education. Almost half of them never attended any on a job training. The minority only have been examined by an occupational physician, and only few companies actually offer health promotion activity. He's a tough guy. You see it. He works long hours per week. He has a comparable low income and a low public appreciation for his work. If you take into account all these factors, we know that we are talking about a rather unhealthy guy. And we know that unhealthy guys produce more crashes than healthy guys. So that's what DocSOP is actually working about to improve road safety. Studies have highlighted several of these health risks like alcohol consumption, smoking, cardiovascular disease, all these types of health risks, including injuries, and that's what I want to talk about. A great problem is that we don't have valid data on injuries on truck drivers. We have a few European-based data on truck drivers which are overrepresented when we are talking about minor injuries, moderate severe injuries, while on the other hand side, the other road user, the opponent, is overrepresented when we are talking about serious or even fatal injuries. There's only one hospital-based study on the frequency of injuries per body region or specific injuries. And as you can see, the injury pattern is comparable to that we know from other occupants, car occupants whatsoever, with high frequency of lower limb and upper limb injuries and also head injuries. So despite this unspecified data on injuries, we know that orthopedic diseases and trauma, meaning injuries, have a major health impact, meaning they have a significant long-term impact. And while we don't have any sufficient data on acute injuries and acute diseases, we have large databases from insurance companies on the long-term impact of these diseases. On these two illustrations, you can see the relative risk of having one of these selected injuries or diseases if you're a truck driver compared to those who are not a truck driver. And you can see that injuries and musculoskeletal diseases are always ranked between the top 4 or 5 diseases when it comes to temporary disability or permanent disability. So if we are thinking of our subspecialties, be it emergency surgery, be it orthopedic surgery, be it trauma surgery, he is one of our dominant patients, and since he will grow in numbers, he will probably be one of our more and more important patients in the future. What is DocSOP? DocSOP is a European network that seeks to provide especially long-distance truckers with medical care on the road, because the long-distance truckers is away from home. He cannot go to the family physician. He cannot ask his wife every day to remind him to take some drugs whatsoever. So there is need for a medical care on the road for these drivers. DocSOP was founded in 2007 by Dr. Koch, who is a member of the European Parliament and very active activator, and Mr. Bernickel, who is a former police officer. DocSOP is registered as a non-profit organization and today supported by private transport companies, vehicle manufacturers, healthcare providers, and others. DocSOP is only working in a honorary capacity, and the German network today comprises about approximately 300 care providers, meaning universities, hospitals, private practices, and so on. But also the DocSOP's European network is growing, especially in Eastern Europe, and the purpose of my presentation today is to sort of inform you about what is going on with the DocSOP network and Well, finally ask for your support by simply registering your institution or your person to the DocStop network. I will come back later to this issue. So how do the driver access an institution that is a DocStop partner? There's 3 very simple ways. First, they can call a 24/7 hotline, which is named here, which is provided in cooperation with ADAC of Germany. The operators speak most of the European language, and they can direct every driver, no matter where he comes from, to the best suitable healthcare provider located directly in the area where he's actually driving. Next option is to have the map and guide software, which is one of the leading softwares for truck drivers, and all the registered institutions are listed in this software, so the software can easily direct you to the next healthcare provider. Or just simply download the list of healthcare providers from the DocStop website. A DocStop provider or DocStop partner, do you have to ask for any legal financing whatsoever issues? No. No. The driver that comes to you, the truck driver that comes to you, is a regular patient. Just a regular patient, no matter if he's an emergency case or if he seeks for any other health care. You can follow your regular institutional care algorithm, including triage or whatsoever, but please keep the truck driver in mind, because the truck driver believes in sort of an informed consent to get his care as soon as possible, because he needs to get back on the road. He needs to get back on the road. And this is what DocStop stands for this informed consent. We all know that in a regular waiting room, there's lots of patients who don't care if they wait another 10 minutes. The truck driver does care if he has to wait another 10 minutes. And if he knows that he had a long time, he will not seek care at all. And that means that he's at a substantial risk for any further injuries or crashes. Payment and all else administrative issues are just like with the regular patients, so there's no problems with that. How can you register at the DocStop network? It's very simple. Check your own resources, especially where is the location of the entrance. A navigation software directs the driver to the parking space, but the driver needs to know where's the entrance of my department, where's the reception of the department. So just write a brief description, just a few sentences. Is there enough parking space for large trucks? Can they maneuver their trucks? Which departments are open to truck drivers? What are the service hours? And are there any special offers or special limitations? DocStop needs to know all this, but that's up to you. Every help, every single help is welcome. Then go to the DocStop online website, just register, which is an easy step, only few steps, only few minutes, and you will receive a package with promotion material so you can prove your participation at the network to the public and, of course, to the driver. Well, that's it. Thank you very much.
Thank you very much again, Uli Schmucker. I'm always fascinated. So they started in 2007, and the network is now all over Europe, more or less all over Europe. So what is the background? You must have a retired police officer and a member of parliament, the member of a European parliament, and it will work. So like it's doing here. I think it's a fascinating idea, and hopefully they can follow it all over Europe. Now, are there any questions to this DocStop system?
Award for the health system. I mean, what is the award for the health system to take the busy truck driver and not the small crying child with a distorted elbow, or what? Should we treat the DocStop first, or what is the?
The truck driver has one substantial problem. If he is, imagine you're a Danish truck driver and you are driving to Lithuania. You don't speak the language.
Okay.
It's 9 p.m.
I
and you don't know
understand
where you are. And you have to deliver your carriage 2 hours later, but you have incredible back pain. This is a situation where DocStop can actually help. So call the number, they will tell you, and there's this basic informed consent that the DocStop network partner will care for you as soon as possible.
Next.
But excuse me, the question, as I understood, was what is the interest of the doctor to join DocStop and to have the problem that during your office hours there's a truck driver coming in, stopping everything else, and what is the interest of the doctor in it?
Actually, there cannot be any financial interest. This is a simple mean and a simple support to a thing that, to my impression, can substantially increase road safety. That's it.
So there should be something in it. I mean, they might have insurance and things like that, or what, maybe. But I understand that it is a kind of awareness. So how is it? One thing is that the health people, we can understand it, but do the truck drivers, do they understand it?
Yeah, they do.
How many long-distance truck drivers are in the system?
In Germany, it's approximately 400,000. Truck drivers. We have, yeah.
That's fabulous.
And we actually don't know how many of them do know DocStop. But DocStop is very, very popular. So every gas station, everywhere you will find a DocStop logo like this. So this, I guess, one of the most popular truck drivers' activities.
Okay, I think you just asked the questions that I want to ask. It was like truck drivers are tough, as you said. So do they go more often to DocStop than hospital, for example?
To be honest, I don't know. But I know that many of them go to DocStop partners, if there's one in their area.
And is there some DocStop around Europe?
The most dense network is in Germany. So we have around 300 partners in Germany. Most of them situated close to the big motorways, of course. And we are now about to roll out the system over to Europe. So we have around 50 partners in Poland, and we have almost no partner in Spain. So still there's a lot to do to tighten this network all over Europe. Well, that's a task for the next years.
Yes, thank you very much. We are running out of time. The Society's General Assembly is going to start at 5:45, and we were asked to finish on time. I would like to invite the next speaker, Stefanie Weber. She comes from the University in Regensburg and holds a diploma in psychology. And she works for the traffic accident so there's something like a traffic accident research institution located at the university in Regensburg, and it's run by Audi, so by the automotive industry. And they ask us in Germany in different locations from the industry to support them with different questions, which are asking us to answer with our data we collect in those institutions. And she's going to focus a talk which is quite complicated to me, so it's capabilities of driver assistance systems in accident scenarios and interdisciplinary interconnection analysis based on real accident data used as approach for the potential evaluation of driver assistance systems. Please.
Thank you very much. I hope it will not be that complicated after I finish my speech. Actually, I'm really talking about the point of view of the vehicle manufacturers. So what we can do when we are dealing with driver assistance systems that are more and more used to be in the cars, and do they have any impact that they really are necessary and that we can tell the people who are driving the cars, who are paying for the new car, that they are really useful. So what I like to mention is I'd like to introduce our accident research unit, which is the Audi Accident Research Unit, and the way we are working. The next one is I like to tell you what we did in the study, and finally, certainly, I'm gonna show you some of the results and the findings we got. So who is ARU? ARU stands for the Audi Accident Research Unit, which is a cooperation between the University Clinical Medical Center, where their psychologists are located and the medical researchers are located, and as well as the engineers from Audi. So we have the technical part from the car manufacturer as well. We are supported by the Bavarian police, and the area we have a look at the accidents that happen is the whole of Bavaria. So what are our objectives and tasks? Well, the main objective is the improvement of general traffic safety, and that's what we are talking here about. The details we are doing is that we have to have product monitoring and the efficiency check of the safety equipment of our Audi models. And we also have some medical, psychological, and technical input for further development of active and passive vehicle safety systems. So how do we come to the data we need to do studies like this? Well, first, when there is an accident somewhere in the Bavaria, the police is supposed to inform us about the accident. They are supposed to do so when there are some criteria met. The criteria are that there's an Audi vehicle involved that is not older than 2 years, so it's a so-called young vehicle, so we can learn for the further development of the cars. There's supposed to be someone injured, so it's not only like a bumper on the parking lot, so it is more of a severe accident. Or there was an deployment of the airbag, that would be a criteria, or there's a heavy deformation of the car. Once the criteria are met, the police is able to call us on a 24/7 hotline to give us the information about the accident. And once we start working at the accident, we really like to have a look at the accident. We are doing this in 3 different teams. The first team is the team technology, which deals with the environmental aspects of the accident. So the team is really going outside to the accident scene to have a look what the environment, what the street looked like. They're also doing the measurement of the cars. So they have a look at the damage of the cars. They're getting some data from this, which all leads to reconstruction of the accident in a computer-based way. So we finally have a kind of simulation and the computer to have an idea what the accident looked like. The second team is the team medicine. So there we are dealing with the outcome of the accident. So we're having a look at the injuries that the people suffered from the accident. And the people who are working in that team also are gathering the personal data, so we're able to get in contact with those people who were involved in the accident. The third team is the team psychology. There, where we are talking to the drivers to get an idea what the accident looked like, or the time before the accident looked like for them. So we get an idea why the accident happened and what were supposed to be influencing factors. Once the work's done from all those 3 teams, we are coming together, we're having a big meeting talking about each case, linking the medical, the technical, and the psychological result dealing with this one special case. So we're able to recognize those data in an anonymized way. So the requirements to really solve the problem, answer the question, what are the capabilities of driver assistance systems, is that we have to answer 3 different questions. The first question is how to avoid an accident. The second is how to reduce injuries. And the third is which requirements have to be applied to do so. So for the first question, we need the knowledge of the accident causes. That's the part that the psychology team takes responsibility for. For the second question, we need knowledge of the accident outcome. That's where the medical expertise comes in. And for the third question, it's the knowledge of the accident sequence that we need. That's where the technical expertise come in. So for the knowledge of the accident causes, we are using the so-called 5-step method to get an information about the so-called pre-crash phase. So when you have a look at all us humans, we have some psychological process going on. Whatever thing we are like to do, we're up to doing. Those steps are the perception, the decision to do something, and the execution of doing it. We can split this into 5 steps, 5 categories. So that's why we're calling it the 5-step method. So the first is the information access. So like we have to make sure if the information really is available, or is there something hiding the information so that the person is not able to see the information. If the information access is there, we have to look if the information really gets to the driver. So if the information reception is working, or is he distracted by something else, so he might not be able to really get the information he needs. When he gets the information, then we are at the next step, the information processing. So once I have the information, I have to process it in the correct way. At the next step, have an objective to do, and finally do it. So you might have an idea that there are different possibilities that there might be a mistake going on. So once there is a mistake in this step, there might be the accident. The second question we were asking were about the consequences. So we know the outcome. We need to know the outcome of the accident. That's where we use the abbreviated injury scale for document the injuries to get an idea how severe the injury is. So that's something that comes out. We call it the little man. So from the information we get from speaking to the patients, either in the hospital or later on by phone, we can get an information about what they suffered from the accident. And if they allow us, we also get the medical stuff, medical reports from hospitals, so we can objectify the information we got. And summarize this in those so-called little men to get an idea what the people suffered. The third part is the knowledge of the accident sequence. Like I mentioned before, it's the accident reconstruction. So we have the possibility to evaluate the technical solutions. That's what, looked on the right side, you see a picture of the computer simulation of the accident. So those are like 6 pictures in a row that happened, compiled to one picture at all, when a car hits a truck. And on the left-hand side, you see what the car looked like after the accident. So the study I'm talking about, how did we get the sample we came up to? Because like I said, we are looking at the Audi model, so we're not really, so we had to need to make something to be representative. So we had to look at the overall accidents in Bavaria from the year 2005. We compared most of the key figures, so our sample fits the overall percentage in Bavaria in, I think, really good ways. So just one example, it's the type of accident. You have the 7 types of accidents. And as you see, the difference between the percentage in total Bavaria and the sample of the percentage of our sample, which constitutes of 100 accidents, is not larger than 2%. So what we did do for the comparison was the comparison of possible dependencies of the accident causes and the accident severity, and did that with a technical analysis of the driver assistance system's effectivity. What we needed to do so was the detailed knowledge about every single case, and since we are gathering about approximately 3,000 variables for each case, we had the possibility to really have a detailed look at those accidents. The systems we considered, the driver assistance system we considered, are systems that are already on the market, so we're really able to buy those systems. The first is the so-called adaptive cruise control, which is including collision warning and emergency brake. The second is the so-called side assist, which is a lane change assistance systems. The third is the lane assist, which is a lane departure warning. And the fourth is the night vision assistant. So for the first part of our study, we needed to conclude what the potential of system. So only if there was a positive evaluation from the psychological point of view, which focused on the accident cause, and of the technical point of view, which focused on the system boundaries, and both parts said, that would be a possibility for the assistance system to really prevent the accident, then we had the potential for the driver assistance system. The second part follows the logic that once you have prevented an accident, you also prevent the injuries that would have happened during that accident. And we took out from our study all accidents that were involving intoxicated and unbelted occupants, because like when there's a driver intoxicated or not belted, there might be other things. He does not need to have driver assistance systems to be saved or to avoid the accident. So when we have a look at the influence of the accident volume, in the middle you see the sample. The sample I talked about before, the 100 accidents. On the right-hand side, you see the distribution of the reduction, which was based on the DAS activity analysis. And once again, I took the type of the accident. Then you see overall that there are 25 times no accident. I'd like to focus you on the accident longitudinal traffic, which would be reduced from 28 to 11, mostly done by the system, the adaptive cruise control. For this, so we can summarize at this part that 25 out of the examined accidents could have been prevented by the DAS that we had looked on. So that equals an efficiency of 25%. For the influence of the injury severity, we had a look at the maximum AIS. You see here that divided in for driver and other occupants. In the middle, again, the sample that we had before, the 100 accidents. On the right-hand side, the sample after reduction. So in the sum of all injuries, we have a reduction from 126 to 94 for the drivers, and for 47 to 33 for the other occupants. And we have a more detailed look at what type of injuries we are talking about. There's a big change for the minor injuries, from 89 to 62 for the driver and 33 to 25 for the other occupants. But what I really like to emphasize is that there's also some reduction from the MI6. So the life of one driver and one other occupant could have been saved when the systems would have worked, would have been there, and would have worked. So to summarize that part, we can say that the systems have the potential to reduce the sum of injured persons by 27%, and out of the 173 people who were injured, 2 fatalities could have been prevented by the examined systems. Certainly, we have to keep in mind that we are talking about idealized requirements, so we would have 100% process safety as well as 100% spread of the DAS, and that the driver really intubated in the postulated time interval without any delay or panic. But I think we're really able to say that the study shows that the DAS that are already existing in the market would have prevented 25 out of the 100 examined accidents, that the interdisciplinary method we're doing with linking the psychological, the technical, and the medical point of view allows the evaluation of the effectivity of future driver assistance systems. Therefore, we need the detailed knowledge to really go deep study and have a look at those things. And certainly, it does not replace any effectivity analysis of driver assistance systems or the consideration regarding the effectivity of the combined driver assistance systems. So thank you very much.